Well, thanks for coming. Shoulder pain is an interest of mine. I see a lot of patients in my office with shoulder pain from many different reasons. There are different reasons for shoulder pain: falls, trauma, overuse. And a lot of the same mechanisms that cause shoulder pain in the athlete will cause shoulder pain in the husband who's put off 6 months of yard work and tries to do it in 2 days. So I just want to start off with a few anatomy points just so we get our terms together. There are three main bones in the shoulder. You got the humerus, the scapula, and the clavicle. We also have joints and ligaments. The ligaments are what hold the bones together. Joint capsules help stabilize the joints. There's also a structure called the labrum, which deepens the socket in the shoulder joint to give it more stability. The main stabilizer of the shoulder is the rotator cuff. Gotcha. Okay. It works. It's basically four muscles and tendons that surround the shoulder. It helps move the shoulder, but also stabilizes the humeral head, which is the ball, in its socket. And when you start getting dysfunction of the rotator cuff, we start developing pain and weakness. So this is putting it all together. We have our humeral head. This is a glenoid. So if you look at the shoulder joint, it's a very big ball and a very small cup. Some people call it a golf ball on a tee. So the shoulder has the most range of motion of any joint in the body, but it probably has the most instability. And so to help keep it stable, we have the capsules, the ligaments, which are more static stabilizers. You have the rotator cuff, which is more of a dynamic stabilizer. If you see here, this is the supraspinatus tendon, which is one of the rotator cuff tendons. And it's more commonly implicated in rotator cuff problems because it goes between two bones. This is called the acromion up here, and you have the humeral head here. So this tendon can get pinched. And for it to glide, we have what's called a bursa, which is a little sac of fluid right there, and that allows the shoulder to glide up and down without rubbing the tendon away. However, we do have problems with what's called impingement. When that tendon starts pinching, it gets inflamed, it gets swollen. The bursa can get inflamed and swollen. And that inflamed bursa is bursitis, inflamed tendon is tendonitis, and they both go together to cause what's called impingement syndrome. Now, again, there are many causes. You have direct trauma in basketball. We have overhead athletes like tennis players, baseball players, swimmers. We have bike riders crashing. I know that's going to hurt. Pitchers, pitchers, to be able to pitch the velocity of their pitching, their shoulder's moving abnormally. The shoulder is not really built to rotate that much. And so they're putting abnormal stresses on the rotator cuff, abnormal stresses on their tendons, on their capsule. We have a lot, and again, it's going to be also overhead repetitive use, like all these guys in the speed bags. That's going to cause some pain if they're not doing the correct activities. And we also have younger players who may not be throwing correctly, but they're throwing 365 days a year and not resting. So this is what we call the impingement syndrome. As you lift up the shoulder, you can see that the tendon, the bursa, is getting pinched under the acromion. And that leads to inflammation of both the tendon and the bursa. And the problem with that is you only have a finite space in what's called the subacromial space. If the tendon and the bursa gets inflamed, they get swollen. If they get swollen, there's less space. And then they get more swollen. And then they get painful. And then it's painful, and then they get weak because it hurts to use them. And since the tendon is not strong enough to keep the joint centered, that humeral head will start rising up. And so it's kind of a vicious circle. This is just another diagram here. You see the bursa here, the tendon here, and as you're lifting your arm up, it's pinching. Now, the rotator cuff helps keep that shoulder depressed in the joint. And if it gets weak, it starts riding up, you'll get more impingement. Now, how many people here have had shoulder pain? Okay. I won't ask you to raise your arms again because it probably hurts. Now, other things that can lead to impingement are not just the inflammation, but people develop bone spurs. So here is what's called the acromion here. It's nice and flat. Those persons developed a bone spur, and sometimes they're born with it. Sometimes one of the ligaments calcifies, and the bone spur develops over time. And as you can imagine, there's less space, and that will make the impingement symptoms worse. As far as treatment for this, first of all, you got to stop the offending activity. So if you've been pitching or lifting boxes or boxing, you may need to rest for a bit. It's mainly an inflammatory problem as well, so anti-inflammatory medications are one of my mainstays. Some people can't take anti-inflammatories or they need a stronger effect, so sometimes a steroid injection right in that bursa will help. Physical therapy helps as well, because the problem is once we get painful, you get weak. People don't move their shoulder because it hurts. The shoulder gets tight, the capsule contracts. And so the therapist will help regain the motion. Initially, they're trying to get the inflammation under control, get the pain under control, but we need to get the strength back as well as regain the motion. Now, occasionally we get what's called calcific tendinitis, where people aren't completely sure why it happens. It may be because of chronic inflammation in the tendon, but people develop calcific deposits in the tendon. If you can imagine this thing getting caught every time they're moving it up. And that can be very painful, because that calcific deposit can actually, sometimes it can leak into the bursa, and you can get very acute, excruciating pain. And a lot of times with these, we'll go straight to a steroid injection rather than give it time with anti-inflammatories. But anti-inflammatories and therapy will help. And occasionally with impingement and calcific tendinitis, surgery helps too. Sometimes the bursa gets so chronically inflamed, no matter how much therapy or anti-inflammatories we're using, the inflammation's not going to go away, and you got to get out and trim out that inflamed bursa. Sometimes we got to get rid of the rotator cuff, the calcifications. And if you have a bone spur, we get rid of that too. Now, often, with chronic inflammation and people putting up with it and thinking that they can work through it, the tendon will start to weaken. And as we get older, the blood supply to the tendon lessens. It's more prone to getting tears. And so you can get basically early inflammation. We can get partial thickness tears. And often this inflamed tendon or partial thickness rotator cuff tear can be adequately treated with physical therapy, anti-inflammatories, and the same things we're treating the impingement syndrome with. But occasionally it doesn't work. Sometimes the rotator cuff tear progresses. Small tears may get bigger. But there are people who have had a small tear which has progressed over time, and they've compensated. They use their other muscles, have compensated for it. So, I've seen a softball pitcher, and he's in his 60s, and he's doing great, and he has a complete rotator cuff tear. And I told him I could probably get him worse with surgery, because right now he's winning. But when we get the big tears or the acute tears, they may not respond well to therapy, especially in a younger patient, an athlete who hasn't had time to compensate. They'll probably end up going to have surgery. Maria Sharapova developed a rotator cuff tear. So it can be acute injury, but even in athletes with repetitive overhead use, such as pitchers, tennis players, rowers, lifters, they may develop rotator cuff tears as well. Often what we do a plain x-ray will show us the joint, it'll show us arthritis, it'll show us bone spurs or calcifications. It won't show us a rotator cuff tear. And so what we usually do is we'll order an MRI. This is a normal MRI. There's a rotator cuff muscle. That's gray. This black is the tendon. It's attaching right there normally. This little white fluid, that's the bursa. This is the joint down here. Now this is a complete tear. This is the end of the tendon. It should be over here. So that's retracted and pulled back. And then sometimes you get these partial tears, not completely through. In certain people, more low demand people, they may do fine with non-operative treatment. But in the big tears, usually we end up repairing them. They used to do it open. Now we do it arthroscopically. The principles are the same. We need to get the tendon back to the bone, and we have to give it time to heal. So usually we can do this with 4 small little poke hole incisions, and outpatient surgery may take a couple hours. But this is a picture of once you've gotten the bursa out of the way, this is what a rotator cuff tendon tear looks like. And this is the edge of the tendon. It should be down here. This is the bone where it's attaching. And this is after we fix it. So we put little anchors in the bone which have stitches attached to it. We use that to sew that down to the bone. But there is a prolonged recovery period with this because we need the tendon to attach to the bone. It's not just the sutures holding it in place that's strong enough to stabilize it. So often these people will be in a sling for 4 to 6 weeks before we even start moving it. Now, other issues that can cause pain. The biceps tendon is also, it's actually one of the few tendons that goes through a joint. It's in the joint, it's right adjacent to the bursa and the rotator cuff tendon. And often what happens when you have rotator cuff pathology, you'll also get bicep tendon pathology. Or when the rotator cuff is inflamed and weakened, the bicep tendon is overloaded, and that can get inflamed as well. So often, non-operative treatment for rotator cuff pathology will also treat the biceps tendon. Now, rotator cuff pain, you're going to have more pain on the outside of your shoulder. Bicep tendon pain is in the front. It may radiate down the front of your biceps. But we see this a lot. We see it in tennis players, baseball players, swimmers. And again, in the absence of a tear, often physical therapy and anti-inflammatories and time and rest will lead to resolution of the pain. Occasionally, though, the biceps tendon will rupture. It may be from chronic inflammation. It may be just from a weightlifter, or someone lifting something up in the garage, and it pulls right off where it's attached. Now, the good thing about the biceps tendon is it's attached in 2 places. And so with a biceps tendon rupture, you'll get a deformity of the arm. They call that the Popeye deformity. But if it's an isolated biceps tendon rupture with no other problem, you may not have any pain, and the pain may rapidly resolve within a week. Sometimes patients have had chronic biceps pain and possibly a partial tear, and it ruptures, and within a week or 2 the pain's gone. But it's also associated with rotator cuff pain. So if you have a biceps tendon rupture, your shoulder is still hurting, you want to look at the rotator cuff. You don't want to just assume it's a biceps tendon problem. So you may want to get an MRI of that as well. As far as biceps tendon injuries, again, it's often a cosmetic injury with a rupture, unless you're an overhead athlete or bodybuilders. They like to be symmetrical. Now, the next thing that can cause pain is the labrum in the shoulder. Now, again, the shoulder is a very, very shallow socket, a very big ball, and it can be unstable. So this labrum is a circumferential cartilage that deepens the socket, and the biceps tendon attaches up here. The shoulder capsule attached to that, and that'll form ligaments which help stabilize the shoulder. But sometimes we can get tears in the labrum itself. So this is called a slap tear, which stands for superior labrum up top, anterior to posterior. And you can see that with throwers, with dislocations, with trauma. But we can also see that just happens over time with attritional damage to the labrum. A pitcher with that may notice decreased velocity in the pitching. He may complain of a dead arm. So that is something that we'll usually evaluate with an MRI as well. Again, with the labral tears, there are different types. Some degenerative tears may do quite well without surgery. Sometimes repairing that, especially in an older patient, may make the shoulder abnormally stiff and painful. So sometimes we'll go in there and we'll just trim it up. And if where the bicep tendon here attaches is unstable, sometimes what we'll do is actually cut that and attach the biceps to the humerus, because in an attritional degenerative tear, the tissue here is not very good, and trying to repair degenerated tissue is not going to work. But when you want to look at a labral tear or maybe a partial cuff tear, your doctor will probably order an MRI with contrast. And what they do is they'll put a needle in the joint, inject some contrast, And what that does will outline the tear, because sometimes with a regular MRI without contrast, you miss a labral tear. So this is your normal labrum. It's attached to the glenoid. This is where it's detached. And that'll cause popping and locking and pain and weakness. But this is how we fix it. This is the same type of tear that you saw that previous MRI. The labrum's pulled off the top. The biceps tendon is unstable because it's not really attached to much. And so what we're doing is we're putting an anchor into the bone here with a couple of stitches around here, and we're repairing that cartilage, labrum, and biceps complex back down to the to what's called the glenoid here. Other things that can cause pain: shoulder instability. Often this is seen in the younger athlete with a dislocation. She dislocated her shoulder right during a basketball game. This is the humeral head. It's out of the joint. They popped it back in. They went on to win. But often it's associated with a tear of not the superior labrum, but what's called the anterior inferior labrum. You see this better again with a contrast MRI. So now we're looking down from the top. This is the front. Before we saw the labrum pulled off the top, this is the front of the labrum. And this is the posterior labrum. That's nicely attached. The front's pulled off. The treatment, again, with a shoulder dislocation or instability can be operative or non-operative. In the young patient, it's much more common that it'll happen over and over again. And if the initial dislocation in someone under 16, 18, they probably have a 70% chance of it happening. If it happens twice, maybe 90%. And every time it dislocates, you can cause damage to the cartilage, which we can't always fix. In an older patient, they're less likely to dislocate again. They're more likely to have a rotator cuff tear. So again, we may want to get an MRI, not just look for the labrum in an older patient, but make sure they didn't tear the rotator cuff. And again, we can now repair this arthroscopically. We're putting this little anchor into the bone, has stitches attached to it, and we're sewing that labrum back in place. Next joint in the shoulder we'll look at is what's called the acromioclavicular or AC joint. This is what people call the shoulder joint. It's a glenohumeral joint. That's the glenoid, that's the humerus. But you have a joint between the clavicle and your scapula here. People can develop inflammation in that area, but they can also dislocate it. And to dislocate it, you got to tear that. And you have several structures. You have what's called the corticoclavicular ligaments, which help stabilize the clavicle. The joint capsule of the acromioclavicular joint also can stabilize the capsule. So this often happens when a patient falls on his outstretched arm or may fall on his shoulder. I see it in snowboarders, road racers, mountain bike racers. There are 3 different grades, actually 6 different grades, but 3 we'll look at today. A type 1 is just a damage to the joint itself, and that's going to heal pretty uneventfully. A type 2, we damage the joint. We may have actually a damage to one of these ligaments. A type 3, you damage both of those. Most of these we can still treat non-operatively. You may end up with a small bump. This gentleman was playing rugby and dislocated his joint. He's probably going to do fine without surgery. This young lady doesn't like the way it looks. And that may be more of a type 5 dislocation where it's severely injured, the ligaments are torn, and that clavicle is going up into the muscle. And that's something we're going to repair. Now we also see arthritis or arthrosis of the acromioclavicular joint. A lot of people have asymptomatic arthritis, so you'll see a bump there, but it won't hurt, it won't be painful, it's not going to cause them any problems. Sometimes, however, you'll get a bone spur down the bottom, and that's going to be affecting the bursa, maybe affecting the tendon. Weightlifters, especially bench pressers, you'll see will get what's called osteolysis, an inflammation of that joint. Now we can treat that with anti-inflammatories, sometimes cortisone injections right in the joint, but that remains symptomatic. Sometimes we do what's called a distal clavicle resection and actually cut off the end of the clavicle here. Because what you don't see in this diagram, you still have those ligaments stabilizing the clavicle, and you don't have those 2 arthritic pieces of bone rubbing against each other anymore. Now this is what I'm seeing a lot of because my patients won't stop riding their bikes, is you get clavicle fractures. This is from a road biker who crashed. They used to treat these mostly non-operatively, but the problem was a lot of these fractures would end up healing shortened, displaced, and it's a lot easier to fix it the first time than going back, cutting the bone open, putting a bone graft, putting a plate on, and hoping it's going to heal again. So we usually fix this with a plate. This patient, I have a patient similar to this, who 8 weeks later went out and rode her bike down a hill again. The plate held, she dislocated her AC joint. I refused to operate on her because she won't listen to me. We can also get fractures of the humerus. This looks real bad. That's not going to require surgery. That's all actually in pretty good position. So this is going to be treated non-operatively. This is again from trauma, falls. Fractures down here that are displaced, however, we're going to be fixing. This is not always a weekend warrior unless you're falling off a roof or doing something else. But we're fixing this with plate and screws, which enables us to get the shoulder moving again and avoid stiffness. Now, there are other causes of shoulder pain. Don't always assume it's a shoulder. I saw a lady today who came in with shoulder pain. It didn't actually hurt when she moved her shoulder. It felt better when she moved her shoulder. Her arm was hanging down, her hand was numb. So it's probably that. She's probably got a pinched nerve in her neck. So you can often get referred pain from other areas in the body, not just the shoulder, but they'll come to you with shoulder pain. We can get arthritis in the shoulder, which doesn't affect the athlete as much, except a friend of mine who's been hitting the speed bag for 45 years and got x-rays, and he's got an 80-year-old shoulder now. Infection is a very rare cause of shoulder pain, but the patient's going to be sick. It's going to be red and swollen, and they'll have a fever. Shingles can cause pain in that area. It depends what dermatome is affected. But again, a bulging disc affecting the nerves will cause shoulder pain or arm pain. Heart disease or a heart attack. Cardiac ischemia can cause pain radiating to the left shoulder. Sometimes patients in gallbladder disease will get pain radiating to the right shoulder. Sometimes patients with pulmonary disease, a tumor or pneumonia affecting the upper lobes, will get shoulder pain. But a lot of these pains with referred pain to the shoulder, they won't hurt when I move the shoulder. So it's not just a complaint, but the exam makes a difference as well. So basically, shoulder pain can be caused from a lot of different factors. It's something you don't want to, if it's been going on for several weeks, you don't want to work through it. Sometimes I see patients who have been putting up with it for 3 years, and by the time they come in, their rotator cuff has torn, it's retracted, and we can't always fix them. So, if it's been going on for several weeks, or if it's catching, or if you have weakness and you can't move your shoulder, talk to your doctor, come see us, we'll take a look.